upon and talk a little bit more in detail, as well as some of the things that we do to try to stabilize these patients and some of the materials that we need to be familiar with for treating these patients, such as AEDs, crash carts, all that wonderful, fun, exciting stuff. Let me get us pulled up here. Right. Sure to see all your faces. By the way, I'll give you guys a little secret. If any of you are thinking of any devious plans to offer me a food challenge, I'll be straight up. My biggest weakness is textures, weird textures on stuff. Make sure you can use your imagination on that. If you want to make the teacher puke, find something with a weird texture. Okay, so medical emergencies, everybody. This is chapter 20 in your book. We're going to get started here. So first thing here, what constitutes an emergency? Well, to put it in the most simplest of terms, that's a situation in which a condition of the patient or a sudden change in medical status necessitates what we call immediate attention and action. And many situations fall under those two categories. But what we're focused on today is the ones that require immediate attention and action. Many emergencies come in, but not all facilitate the need for the immediate action and attention. The ones we're focused on today, for example, cardiac arrests, shock, things like that, those would constitute us to react quickly, efficiently, and with what we call that immediate attention and immediate action. Otherwise, there's going to be severe damage to our patients, and or they're going to progressively worsen if we don't attend to that with punctual attention and action, and proper as well. So we're going to focus on those specific emergencies today and break them down, talk about many of the materials that we will use, many of the equipment pieces that we'll use to help reverse those emergencies and save our patients' lives and give the best care possible. Ooh, I think that chip fried my vocal cords. Raspy today. So, gory pictures there. But this is all real stuff that you will see in the hospital environment. Not to freak you out, but this is very common occurrences that we will all see at least once. I put these in here for a reason because if you have not seen cases like this yet, you will. You've got to learn to react to it properly. I want you to think about this for a second right now. Think about yourself right now. If you're a technologist and you're called to that trauma room, and you walk in and see a patient with their head split open like that, or their hand cut in half, and you're told, hey, who am I going to pick on? Hey, I'm going to pick on you because you reacted the worst. Hey, Jessley, I need a 3-view hand. Can you give that to me? What would be your reaction? Are you going to be like, oh my God, I can't do it? Or are you going to do your job? Could you do your job?
Yeah, there's a way, but at the moment I can't think of it.
Now, why am I showing this as well? Because think of that same situation. You're called in to do a 3-view hand x-ray. Can you do a traditional 3-view hand x-ray on that hand?
Traditional, no.
No. So what would you have to do? Critical thinking skills to deliver the best possible images with that situation at hand. If you're told a head x-ray, go ahead, Jessley.
So I was like, wait, so how would you do it? What, like this?
You could still do a 3-view, but you'd probably do a cross-table lateral, for example, because you could not move that hand into a lateral position. Easily get your PA. You could get your oblique, but you need to do a cross-table to acquire that lateral because you can't turn that hand, or you may further injure that patient, worsen the injury. That's one of the things we have to take into consideration as well. Are you going to make the injury worse by moving that patient? Therefore, we have to critically think how to acquire that image efficiently, fast. And if you haven't been in the trauma room yet, guys, or the shock room, it's fast and intense. You can't sit there and think about what you're going to do for 10 minutes. You got to get in there, acquire the image, and get out the way. Because they may be doing CPR while you're doing that hand x-ray or that head x-ray. They may be delivering oxygen while they're trying to bring that patient back to life while you're doing that x-ray. People are screaming, people are cursing, people are running all over the place with their heads cut off, acting like they have their heads cut off. But you still got a job to do quickly, efficiently, and accurately with good quality x-rays. Can you do it? Yes, you can. You can do it. If you don't think you can, yes, you can. And you're going to learn to do that as this process continues in your education. Now, that one on the top there with the nail, I did an x-ray on a patient exactly like that. It was a prisoner that had a nail going through his finger. I have done x-rays like the one on the left. I've done x-rays like all of these right here. They're tough, but they can be done. I think back to a story right now with this person on the left. Probably one of the worst things I saw was a child came in, and this child had been scalped by a pit bull. The child was attacked by a pit bull, and the pit bull had clamped on the top of her forehead and peeled the entire layer of skin off of her skull and had completely eaten the child's ear. So I walk in there and I see this site. It's horrible. It looks very similar to this guy that has basically his brain's exposed there. And I was asked to do a skull x-ray. I had to fight back the emotional impact of that, jump in there and get that good x-ray as fast as possible. So you're going to see that stuff. We had another kid come in, like this x-ray on the bottom right. I call it the lawnmower kid. This kid had their foot caught in a lawnmower, and it looked very similar to that hand you see right there, so it was a foot. And I was asked to do a 3-view foot x-ray. There was not a foot there. It was a mangled up mess. I took the mangled up mess and still got as good a foot x-ray as possible while keeping that patient stable, working fast, efficiently, and getting my job done. That was a crazy incident. I actually was involved in not only the trauma room x-rays of the foot with the lawnmower, but I also was involved in the C-arm case where the parents refused to have that kid's foot amputated. They kept saying, we want you to repair the foot. And when I tell you there was just nothing to repair, if you imagine what a lawnmower does to something, there's nothing there. But they, regardless, went in there on that surgery case and kept trying to repair that foot. And I remember sitting there on that surgery case as they tried to repair that foot by putting pins in what was left of the foot, the bones in the foot, which we're going to learn about next week. And I watched them try to repair the foot as it kept falling apart. They would put the rods in the foot, they would hold it up, it would fall apart. They would put the rods in the foot, hold it up, it would fall apart. Like if this is a foot, look at my hands, it would do this. Falling apart and disintegrating until there just was nothing left to repair. And long story short, they ended up amputating that foot. I got off on a tangent there, but you're going to see this kind of crazy stuff, guys. You are going to see this crazy kind of stuff, and you've got to react accordingly. So what is your role? Yes, questions?
So the parents said that they didn't want the child's foot to be amputated. So what did the parents do? Like when they saw his foot amputated? Like it's kind of crazy.
Well, they finally got the parents to agree to the amputation. I think I left that out, but it was days later after they did multiple surgeries trying to repair the foot that they finally had them agree that it had to be cut off because there's just nothing they could do. There was nothing to repair. But some parents they're not going to give up on that. They're not going to give up on that. Okay, so what's your role, guys, as a medical professional imaging employee? Of course, preserve life. It's always preserve life and to avoid further harm to the patient, which is why I showed you some of those images, because part of our job is to get those images done efficiently without hurting the patient further. When you think of fractures, you've got to be able to identify. And what's great about when you have the digital machines there on the trauma room case, you can look immediately after you take that first x-ray and you can see if there's a fracture. You've got to be able to see that stuff and identify it, because if you see a fracture on that first x-ray, your first thought should be, I've got to be a little more careful doing these next few views. I might need to adjust my technique and maybe do some cross tables instead of the traditional way, because if I don't, I'm going to bring further harm to that patient. And the last thing you want to do and put yourself into a situation is worsening a fracture or opening up a wound further because you're not using the proper steps or techniques to take care of that patient while acquiring the images. And that does happen. I mean, I've made the mistake myself where I've made injuries worse because I may have been in a hurry and not paying attention. That happens to everybody, but we've got to prevent that from happening because that can be a huge liability issue or malpractice suit against you in the hospital. You could jeopardize your job if you were to injure a patient severely based on your lack or negligence of the situation. And of course, obtain that appropriate medical assistance as quickly as possible. We're talking a lot about speed today. A lot of these conditions we're going to go over require very fast speed. Now, if you're like me, you don't like to be rushed sometimes. You like to be able to think about what you're doing. But in this type of career field, there are these situations where you have to react as fast as possible and do it efficiently. Sometimes when we work fast, we make mistakes. We've got to learn to work past that and think critically, fastly, efficiently, and deliver that best quality care without hurting our patients even further. And you're going to learn to do that. You're all going to learn to do that, especially if I can, because I was not the kind of person who liked to be rushed. I didn't like being watched. I didn't like people hovering over me and like, leave me alone, let me do my thing. That's not reality. It's not reality, especially when you're in that trauma room. You got 10 people hovering around you, watching your every move, saying, when's this x-ray tech going to hurry up and get out of my way so I can save this person's life? Why are they taking so long? Do they know what they're doing? Where'd they go to school? Hey, manager, your x-ray tech has no business being in this trauma room. Don't ever send them back down here again. You don't want to be that tech. You don't want to be that person who have that reputation. And that reputation will spread fast because we do work in these small environments, these very intimate small environments. So what are some of the kind of emergencies that we're going to go over this chapter? Well, these are the ones that we're going to focus on a lot more clearly and in more detail. That's going to be shock. We're going to spend quite a bit of slides on shock because there are several types of shock. Anaphylaxis, pulmonary embolus, diabetic reactions, something that we encounter a lot in the hospitals and in our own personal lives. I'm sure everyone here knows someone who is diabetic. It's a very common condition. Cerebrovascular accidents, what we call a CVA, that's the shortened term. Cardiac and respiratory failure, we're going to see that constantly. How do we react properly? Well, we all learn how to do CPR. And at any given moment, you may be asked to jump in on a CPR case. I don't know if you guys have been to shock rooms witnessing CPR yet, but yes, you as a tech and you as a student may be asked to take over compressions on a CPR case because if you know anything about CPR, it's very physically demanding. And they might say, hey, Esbede, jump over here and start doing compressions right now. Hey, John, you better start doing some compressions right now. We need to switch out. And you can't say, I don't know. No, you can't do that. You've got to react immediately and jump in there and start doing those compressions and doing them correctly, which is why we learn to do CPR, why we learn to do chest compressions. If someone says, hey, Daniel, go grab the AED, you can't say, I don't know where the AED is. What's an AED? Hey, Naomi, go get the AED. I've never heard of that before. Sorry, I'm just a student. No, we can't say that. You should always know where the AED is because you may be asked to do that in an extreme situation. Syncope and seizures, two more things that we're going to go over specifically and specify and define because there are different types involved with those emergencies as well. It's all about that reaction time, always being on your toes, guys, and always being ready and willing to act immediately should you be asked to assist with any of this. And back to what I was saying about the CPR guys, we've had students, multiple students. Mary Gill, I don't know if you guys have met Mary Gill. She works at Ben Taub now. She just graduated. She had to do CPR on a patient. Another student, his name was Milo. He actually helped save a patient's life because he jumped in and started doing compressions. He was actually riding on the stretcher doing compressions from the x-ray room to the trauma room because he immediately reacted and jumped in there and started doing compressions because a patient went code blue during an x-ray. It happens. It happens. There was a student that I went to school with who helped deliver a baby in an x-ray room. A woman went into labor on the x-ray table and she helped deliver a baby on the x-ray table. Stuff happens. We're involved in so many different things that we don't expect, but always expect the unexpected and know how to react properly. So, of course, one of the major things we got to do as well, guys, is stabilize our patients. How are you going to aid in stabilization? Well, how you react, how quickly you react. Your main aid in stabilization is getting in there, recognizing the signs of what's going on in that situation, and acquiring your image and doing your job as quickly and efficiently as possible. I'm going to say it a lot this chapter because that is a very important concept that we have to grab. Speed and efficiency. Speed and efficiency is key to being a good x-ray tech and handling these emergencies properly, especially in our shock and trauma rooms, or if it happens in your X-ray room. Any given moment of any given day, like I just said, patient can go code blue, start going into cardiac arrests in your X-ray room. How would you react? I'm gonna keep saying, how would you react if you were there? Are you gonna run the opposite direction, or are you gonna jump into action immediately? I hope you're saying I would jump into action immediately, because that's what we're training you for. That's what we've got to learn to do. So our emergency priorities, now that very first one, you're gonna see me mention that one a lot. Our main priority always, when any kind of emergency presents itself to us in a hospital or clinic or just even a life environment, always ensure that we have an open airway. And we're going to go over some methods for that as we get closer to some of the choking issues that we face. But we always ensure that that airway is open because the body has to have oxygen flow. If you see a patient choking, not breathing, you need to start that CPR immediately, check that airway, do all those steps needed. If this person's doing the universal choking sign, do you know what to do immediately? You don't go to that patient, ask, are you choking? They say yes. You start that Heimlich maneuver, which we're going to learn about in this chapter as well. React properly and always look for that open airway. Make sure your patient is breathing. If there's bleeding, control the breathing. How do you control bleeding? You put pressure on it. Simplest way. Sometimes that works, sometimes that doesn't. But know how to take the measures to control that bleeding. You may do a hand x-ray, actually knock that band-aid or bandage off, and all of a sudden they're bleeding all over the place. You're not going to run the opposite direction, say, oh my God, I can't deal with blood, it's too much. You need to immediately go to your crash cart or your supplies in your room, get some new gauze, get some bandages, and start wrapping that wound, controlling that bleeding. Yes, that is your responsibility. You're not just going to go call the nurse and let them bleed out on top of that cassette while you're trying to find somebody to help. That's your job to do that. You'll take the proper measures to prevent or treat shock. We're going to learn more about that when we start actually talking about shock. Attend to wounds and fractures, and I'm going to say attend to wounds and fractures properly. Because like I just mentioned before, depending on the wounds, depending on the fracture, we've got to make adjustments to how we do these x-rays. We teach you the basics of x-ray. We'll use a hand again, PA, oblique, lateral. But I can't get stuck on that mindset that I'm always going to do a traditional PA, oblique, and lateral. They still want those 3 x-rays, but I've got to think outside the box to not injure that patient further. Depending on the type of fracture, the type of wound, if I use those traditional techniques, I may cause further injury or harm and get myself into trouble and also cause my patient a lot of unnecessary pain. So I will tell you, and I'm sure you guys can attest to this, raise your hand if every patient you've had so far has had painkillers. No one's raising their hand, and that's the truth of the matter. I'm telling you, and it drives me crazy. I always want to fuss at these nurses. They're notorious for sending patients over to you, whether they have a gaping hole in their hands or they have a bone sticking out of their elbow or their arm. They're always going to come over to the x-ray department. You're saying, have you had any painkillers? No, they haven't given me any painkillers. And you're saying, oh, here we go. This is going to be tougher than it needs to be. So you can't rely on that. They're not always going to give the painkillers, and I can guarantee you 9 times out of 10, they're not going to give painkillers. So you've got to adjust the way you do these x-rays properly to still deliver that efficient quality care. Provide emotional support. That is a big part of what we do as well. Now, not all of us are very good at that. I used to stink at it. I'm not the most emotional person. I'm an extreme introvert, and I know you guys probably don't believe me, but when I worked in the hospital, I could sometimes be kind of a cold person. I was like, I've seen too much. I'm like, get over it. Get over your pain. Just sit there and do my x-ray. But you can't be that way. Everyone reacts differently. There's different personality types. When we do our personality studies, which we're going to do that, by the way, I'll show you what I'm talking about. But you got to be able to gauge the situation and know when you should provide that proper emotional support, those words of encouragement, words of affirmation to people that need it, especially with, and I always go back to kids. I know we don't always deal with kids because adults need it too, but kids especially, they can read how you're reacting so quickly. They can read your face and be like, this person's serious, this person doesn't like me, this person is mad at me, they're rolling their eyes, they're getting grossed out. Kids are a lot smarter than we take credit for. You've got to give that emotional support properly. With our adults, you've got to do that as well. It's going to be okay. You can do this. Let me help you out. Is there anything I can do to make you more comfortable? Get you a warm blanket. I understand it hurts really bad. I can see you're in a lot of pain, sir, ma'am. What can I do to help you? How can I make this more comfortable for you? Those emotional words, while they may seem frivolous at times, go a lot further than we may think with the right or the certain people. Everyone reacts to this stuff differently. You got to get in there and engage that situation properly. You got to learn to read people a little bit. It can be hard to read people, but you got to learn to read people and adjust yourself to those situations properly. Tough to do, but you'll learn to do it. And some of us are more natural at it. I can see some of you right now. I can guess those of you off the top of my head that would be really good in giving emotional support to people. And like I said, I used to stink at it. I was quite horrible. Like, oh, you're fine. Sit there and do the X-ray. You'll be okay. And that's not the right reaction. That's not the right reaction. You got to do it properly and react properly to those patients depending on what's going on. And of course, continually reevaluate and follow up appropriately. You should always reevaluate as you're doing your exams, adjust accordingly, and follow up with the right personnel. If you do need help, follow up with the right person. Call the doctor. Say, hey, sir, doctor, whatever your name is, doctor, whatever. Hey, I've done everything I can to make this patient comfortable. I've got you 2 elbow x-rays. I would like you to take a look at it because this is the absolute best I can do. Are you okay with these x-rays before I send them back? He might say, sure, thank you for communicating with me. Let me know. Let's reevaluate everything. And we might follow up with some more x-rays later after we stabilize the patient, bring their pain down, or fix their situation. Or they might say, you know what, Aurora, I still want that perfect lateral elbow when that elbow is completely disintegrated and the bone's hanging out. At that point, you'd say, okay, I've done everything I can do. You're welcome to come over here and help position for the x-ray, and we can see if we can get you that nice lateral elbow. They may do that, they may not. Now, why am I saying that? Because you're going to have that exact situation happen. We're talking about reevaluating and following up. Every ortho doctor wants a perfect x-ray series of the upper and lower extremities. I'm going to use the elbow again for an example. They always want a perfect 90-degree elbow. And you might get a patient that's so unstable and in so much pain, or that elbow is literally disintegrated, that you cannot get that perfect 90-degree elbow. Now, why did I tell you that story just now about saying, why don't you come over and do it yourself? I don't say it like that. You got to choose your words better. Because you're going to do everything you can at first. You're going to use your critical thinking skills and acquire that great x-ray. But if you cannot get that x-ray yourself, the best response to those doctors, because you will find yourself in this situation, the best response to those doctors is, sir, ma'am, I have taken multiple exposures. Using the best of my skills, I have acquired for you the best x-rays given the situation, but you are welcome to come over here to the x-ray room and position the patient yourself to try to acquire a better x-ray. Now, they're going to respond in 2 ways, one of 2 ways. They're either going to say, that's fine, go ahead and send them back. I'm not qualified to do that. Or you're going to get an arrogant, I'm not going to use the word I want to say, an arrogant doctor, keep this PG, an arrogant doctor that's going to come over and try to do it themselves and make a fool of themselves. But you at least covered your bases by communicating properly and not getting yourself in trouble by doing what they call refuse to do the exam. You communicated that properly, you followed up appropriately. But sometimes those doctors will come over and make a fool of themselves, and that's happened to me about 100 times, more times than I can count. I had a doctor do that exact thing to me. There was a child that literally had a disintegrated elbow. I say disintegrated because the elbow joint was not there. The fracture was so severe that it looked like crumpled up crackers, to put it simply. I did everything I could to get those x-rays. I got a beautiful lateral overall considering the situation. This ortho doctor was very arrogant. I said the exact statement I just told you. Sir, I've done everything I can, but you're welcome to come over here and assist me to see if we can get a better x-ray. He came over, put the patient through severe pain, and got even worse x-rays than the ones I had. So in the end, he said, you know what, I can't do it. We're going to go with your original x-rays. So he made a fool of himself, but that would be the proper response in that type of situation. I'm getting all off subject here. I apologize. But I'm saying that because you are going to find yourself in that kind of situation, especially with ortho docs. It's all in how you respond and follow up accordingly to the right people. And the radiologist as well. Another defense on that is bring your images to the radiologists. Say, hey, are you okay with these images? I've done the best I can. I can't do anything further. Are you okay with reading these? And if they say yes, that's also a great defense on your part. I said, we'll make the best of it. We'll make a read based on that. Thank you for communicating with me. Always goes back to that communication. All right, the crash cart. Who here has had the opportunity to play with the crash cart? Anybody? Okay, Tracy, Esbede. Have you guys watched Daniel? Have you guys watched the text Full with the Crash Cart? Y'all know what I'm talking about? What do the texts have to do with the crash cart? Who can tell me? Every day.
No, every morning they check it to make sure everything's working correctly.
They check to see if everything's working correctly. You're right. And they also check to see if the supplies are all there. And they also check to see if everything's everything's meeting the expiration date, because these supplies have expiration dates. So you as a tech, wherever your rotation is, you're going to have a rotation where you're in charge of the crash cart. You have to do tests on the AED, which every crash cart should have. Now, I know some of you might be saying, my crash cart does not have an AED on it. That's this device right here with defibrillators in case the person goes in cardiac arrest. I don't know why, but some of the crash carts in Harris Health do not have AEDs. And to me, that defeats the purpose of a crash cart, because what happens when a person crashes, we need defibrillators to revive them after we're doing CPR and can't get the pulse back. So this is my assessment. Every crash cart should have an AED, but I know some in Harris Health do not. But everyone should have an AED. And that's something you're going to run tests on, along with checking all these cabinets to make sure the supplies are in there, they are stocked, and that the expiration dates have not expired. If they have expired, you're going to remove that supply. You're going to document that you have removed it due to expiration, and you're going to resupply that supply. Keep adequate count of those supplies. Because the last thing you would want to happen is, let's say a patient crashed, you thought you had everything in there, but you're missing a syringe, or you're missing an oxygen mask, and you got egg on your face while people are trying to find something really quick because you did not have those supplies stocked, or someone else before you screwed up and didn't check it properly. So that's why techs always check these crash carts, or they should be, efficiently, and they document that they have done so in case a situation does happen where something does not work or a supply is missing. They can follow back that chart and see who was in charge of checking it properly, hold that person accountable for not doing what they were supposed to do. So something we should not take for granted. Very important job to always make sure it's stocked properly, expiration dates are current, and that we have all the equipment we need working properly. Specifically that AED, we have to run the tests on there to make sure it actually ignites, it actually does an electrical charge. Because once again, the last thing you want to happen is a patient's in cardiac arrest, get your AED off the crash cart, and it doesn't work. Someone screwed up and didn't check it properly. And we must always, big star there, that's why I have it in yellow, know where that crash cart's located. Once again, keep saying this a lot. Imagine you're in a room. Imagine, Ruth, you're in a room, and a patient goes into shock. They're not breathing. They're going to cardiac arrest. And the nurse says, Ruth, or whoever's in that room, Ruth, go get the crash cart. And you say, I don't know what a crash cart is. We don't want to say that. Son, someone might say, son, go get the crash cart. You'll say, I don't know where it is. I'm just a student. I don't know where it is. That is the wrong response. So your homework after today, when you go back on Tuesday, is whenever you go back to the hospital or clinic, I want you to be able to tell me by next Wednesday where your crash carts are, because you should know where that is located. You have to know where it's located, because you don't want to be in that situation and screw up your reputation. Because remember, you're on a 2-year interview. You got to respond quickly and know exactly where that crash cart is, because you may find yourself in that situation unexpectedly. So that's probably the reaction of most techs when they actually have to check that crash cart. That was my reaction, because I had to check it every night because I work night shifts. I was always in charge of checking it. But as much of a pain as it is, as tedious as it is, it has to be done to cover yourself should a situation arise. And we never know when these situations will arise. This stuff is completely random. We've got to be prepared to respond accordingly and know where those are located. Also, I want to add to that, guys, know where your AEDs are located. You know what I'm talking about with the AED, the ones on the walls? There's always AEDs in every area, much like we need to know where the oxygen is located in the rooms. You need to know where all these are located in your facilities. Because like I said, I don't want any of you stuck in that situation where they're asking you where something is and you don't know. And guess what? You've just embarrassed yourself in front of the staff, but you've also put an X against you whenever you're looking for that job, because they're going to remember this stuff. Well, that student didn't know where the crash cart was. This student knew exactly where it was. Let's hire them because they've been paying attention and they know how to respond quickly and efficiently. True story. You're on a 2-year interview. Take that extra step and find these locations. And that's what they'll traditionally look like right there. say, son, you said the crash cart at Bone Clinic is located. I didn't get to see your whole text there. I'm sorry. But I'm glad you've already identified where that's at. That's great. Everyone should do that. And they typically look like the two pictures I have right here. Most that I've worked with were red colored, but I think the ones at Ben Taub are more gray, more of this gray color. But you'll see them in both varieties. And like I said before, even though they should have AEDs, I know a lot at the Harris Health facilities do not have AEDs, but they typically should have those AEDs located on those crash carts. And all those cabinets should always be locked, by the way, guys. If you ever walk by a crash cart and you bump it or something, or you see a cabinet that's open, you want to let somebody know really quickly, because that should be locked up. It should be completely locked up. You never want it to be completely unlocked. That's how stuff goes missing. Okay, so also, like I said before, guys, aside from that crash cart, know where your oxygen is located. It's another thing very important, because when patients crash, they got to get oxygen to them immediately. And every x-ray room you work in should have the oxygen hookup in that room. If you remember from the last chapter we talked about, it's green colored. Know where that's located. Know where the suction is located. It's usually right next to the oxygen. Know about the contents within those crash carts as well. You know exactly what's in them. And I'm going to go even further. You need to know what drawer the equipment is located in. Once again, you're in that room, your patient's crashing. They say, get me a syringe. And you go to the last drawer. You're like, oh my God, I don't know where the syringe is. Somebody help me. You know what each drawer contains and where those locations of those equipment are. Know where the AED is, because there's AEDs all over the hospital. You should know every location. You might be on a lunch break in the cafeteria and someone goes into cardiac arrest. And I hope you're not going to sit there and just keep eating your hamburger and say, oh, let's watch the show. Let's watch what's going on. This is a good hamburger. Well, sucks for them. I'm just a student. No, you can't do that. You are a medical personnel, you're part of the medical staff now, guys. You are students, but you are part of the medical staff. Your reaction would be to immediately say, someone call a code, someone locate the AED, or if you're asked to locate the AED, you're going to go retrieve it and start working on saving that patient's life. I'm not saying that jokingly. Someone might start choking in the cafeteria. How do you react? Like I said, you're not going to sit there and eat your popcorn and just watch them choke. You're going to run over there quickly, ask them, sir, ma'am, are you choking? Would you like me to help you? They're going to say yes, and you start doing that Heimlich maneuver immediately. We've got to be on our toes, because this stuff can happen. It will happen. You're all going to find yourself in some kind of situation like that eventually. So as far as the AEDs, guys, there are two types. We have what's called the fully automatic defibrillator and the semi-automatic defibrillator. What would be the difference between those two? Who can tell me? Has anyone ever worked with AEDs before? We did work with them in CPR. I hope we all did. That was part of your CPR training. But what is the difference between a fully automatic versus semi-automatic defibrillator?
Fully reads the whole thing and does the shock for you, and semi will tell you, all right, it needs to be a shock, so you administer the shock.
That is correct. So it's literally within the name of the equipment, guys. Fully automatic means it's completely self-reliant. It's going to do everything itself as far as reading, shocking, every part of it. It's going to tell you when to get your hands off the patient and stand back, so on and so forth. Versus semi-automatic, it's going to give you prompts. It's going to say, I'm taking the pulse. You may push you can now activate the shock button. You'll actually activate the shock button yourself. So that's what we call the semi-automatic, because you are involved with pushing that button on that piece of equipment. Fully automatic will do it all for you and give you voice prompts of what's going on. Make sure you know what kind your facility has, because one embarrassing situation would be if you're expecting fully automatic and they have semi-automatic. I would hate if this happened, but you got the pads on the patients, you're getting ready to shock them, and you're sitting there just with your arms crossed waiting for it to shock, sipping your Coke. Nothing's happening. Oh, it's semi-automatic. Oh, I didn't push the button. No, that would be horrible. Don't do that to yourself. Know what kind of AED you have at your facility, so you can expect, if you were found in that situation, exactly what to do. So we're going to talk a little bit about head injuries now. Head injuries are extremely common in the hospital environment, guys. They come in all the time through the EC, through the trauma and shock room, and they can cause extreme damage to the brain, the spinal cord, These are very severe medical emergencies that we have to treat properly and know how to react, because if we are not careful with head injuries, we can cause extreme damage. And I don't put that lightly, extreme damage to our patients due to brain damage and spinal cord damage, permanent paralysis, death. Both of those can occur so easily with these head injuries. Now, that does happen a lot in sports, but that can happen in any kind of situation, especially with wrecks, someone just falling off the roof, even falling out of their bed in a room. They hit their head the wrong way. They can have a concussion. They can fracture their skull, cause hematomas on the brain. There are hundreds of different things that can happen as far as head injuries, but we do have to react quickly and properly on these patients. Number one thing with a head injury patient, guys, never, ever, 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 I'm going to say this 1,000 times, do not ever move a head injury or neck injury patient by yourself. That is a team job only, because you must stabilize the head and spine when you are dealing with a head or spinal injury. If you do not, you will risk injuring that patient and permanently damaging them possibly, or even killing them. So if you know there is a head or spinal cord injury, that is a team effort to move and treat that patient. If you are by yourself, the patient has fallen and hurt their head, do not go into Superman mode and start trying to drag them across the floor by yourself. You call for help immediately and get someone to help you stabilize that patient's head and spine before you move them. That is extremely important. Extremely important. So what are some of the indications for a head injury? These are a few, but not all. We have the typical scalp wounds. That would be like an open wound on the head. A fracture, that would be the actual fractures of the skull and facial bones. Swelling and bruising, much like a bruise that appears anywhere on the body. Loss of consciousness, by the way, that's a very key indication that you're dealing with a head or spinal injury patient. If you see on an order form that the patient has LOC, LOC is the shortening of loss of consciousness. That is something to keep an eye out for. If you see that indication, you need to treat that patient as a head or spinal injury patient. Go back to what I just said. Make sure you are utilizing a team effort in treating and moving that patient. There's techs everywhere, guys. You're working in a hospital, you got techs working with you. Call them to help you, call the nurse to help you. Don't put yourself in that situation where you're going to be by yourself working on that patient. Nasal discharge, specifically blood coming out of the nose, sometimes CSF, cerebrospinal fluid can come out of the nose if there's a bad enough head injury. One of the main indications we look for is that nasal discharge and a stiff neck. If you see any of these kind of indications on an order form dealing with the head or neck, like I just said, you immediately default to that is a head injury, that is a spinal injury patient. I've got to utilize help from other people to move that patient and stabilize them to acquire my x-rays properly. Don't ever do it by yourself. I know I'm saying that a lot, but it's very important. For example, one really bad kind of neck injury that can happen is, anyone ever heard of an internal decapitation? An internal decapitation? Well, what do we know about decapitation? Decapitation is when we sever the head from the neck. What do you think an internal decapitation refers to? Anybody want to guess?
It's be able to.
Say that again, Isbeth. You were cutting out.
I was gonna say it's not gonna decapitate it. So it's if it was no longer functioning in my mind.
Well, you're sort of on the right track. So to put it simply, an internal decapitation, this happens often with a lot of our neck injury patients. The C-spine is fractured to the point that it's completely decapitated within the skin. So you think of a normal decapitation, we have the entire head severed. But internal decapitation is the spine that is actually severed within the skin and has a chance of cutting the spinal cord in half as the bones crisscross. So that's what we call an internal decapitation. So using your imagination for a second, it's just an example of why it's so important that we never deal with these patients by ourselves. Imagine if you had a patient that had an internal decapitation, you didn't know, but you knew they had a neck injury, and you go to try to move that patient on their side, what do you think is going to happen? Those bones are going to shift, the spinal cord becomes severed, and you killed your patient. That does happen. That's why I'm saying it a lot. When it comes to head and spinal injuries, treat them all as if they're absolutely severe and life-threatening, because in many cases they are. Don't ever find yourself in a situation where you're dealing with it by yourself. Ask for help. It is a team effort when we're dealing with head and spinal injury patients. As far as the types of head injuries that are traumatic, guys, this is going to be the percentage levels that we're looking at. 28% are going to come from falls. If you think about the elderly, one thing we know about our elderly patients is they fall a lot, and more often than not, what do they injure? They injure their head and their spine because they fall the wrong way. They hit their head on the floor or on some other kind of blunt object. 20% are going to be our traffic incidents. 19% is going to be an actual blow or strike to the head or neck. 11% is assaults. 9% unknown. 7% other. And then a few other little tiny ones there. Suicide would be 1%. Main ones to remember, guys, though, is that big number you see right there. That 28% come from falls and 20% come from traffic incidents. It's the two most common you're going to see out there in the hospital world. Now, as far as our levels of consciousness goes, guys, there are 4 major levels of consciousness when we deal with head and neck injuries. That's going to be alert and conscious, drowsy, unconscious, and comatose. Part of your job as a tech, if you have a patient coming in that has that suspected LOC, remember once again, LOC refers to loss of consciousness, part of your job as a tech is to document on your x-ray one of those 4 categories when you do your x-ray. So are they alert and conscious? Are they drowsy or lethargic? Lethargic would be the scientific term you could use. Are they completely unconscious or are they comatose? And yes, that is something you need to document when you do your x-ray when it comes to these type of patients. One of those words you're going to get sick of me saying. I'm going to say it from first semester all the way to you graduate. Document everything, guys. Do not ever take that for granted. Document everything like your life depends on it, like your job depends on it, because to put it simply, it does depend on it. Especially in this day and age when everything's traceable. Everything's traceable. Can't hide things like people used to. All those unethical people working in the hospital, they can't hide stuff like they used to anymore. Okay, and that's a good stopping point for today, guys. We're going to wrap it up there today. We're going to get into shock on Monday. So I will send you the PowerPoint so far.